Hello, I'm Suresh Gunasekaran, CEO of University of Iowa Hospitals and Clinics and Associate Vice President for UI Healthcare. We are delighted to again be part of the Iowa Ideas Conference. Now in its fourth year, Iowa Ideas provides a unique opportunity to bring together a wide variety of different voices, perspectives, and thoughts to create a better future for us all. 2020 is a year that none of us could have predicted and has given us unprecedented healthcare challenges. In some ways, these challenges have made us better at delivering care, but it has also further highlighted the serious gaps some Iowans face in receiving adequate healthcare services. Let's start the discussions here and follow through to deliver better health for all. Thank you for being a part of this important discussion.
All right, I hope I have everyone back so far. Again, welcome back to day 2 of the Iowa Ideas Conference. This is Caring for Our Aging Population, session 6 in the healthcare track. Also, don't forget to join us at 11 for closing keynote David Kennedy from the National Network of Safe Communities, followed by our Big Ideas virtual social from noon to 1 p.m. I do want to thank all of our sponsors for making this virtual conference a success. Also, a few quick notes here. If you have any questions or comments that you'd like to ask the panelist, on the right-hand side of your screen, you'll have a chat function, which I will then copy and send to Michael Castranova, who is our room moderator for this session. Michael, I'll turn it over to you.
Thank you, sir. Hi, yes, I am Michael Chevy Castranova. I'm the business editor and also the editor of Iowa Ideas Magazine. Thank you for joining us on our second day of Iowa Ideas Conference during the pandemic. We used to do this at the Doubletree Hotel, and it was a great deal of fun. And so far, this has worked out pretty well. So thank you all for joining us. We are, in fact, going to talk about caring for the aging population, which I know many of you need to deal with, so that we can deal with our parents, deal with our loved ones, deal with our friends who are going through some very exceptionally challenging time. So we have a great panel here, and one of the good things about doing this via the internet is we can bring in all kinds of people no matter where they are. So I'm going to ask each of our panelists to introduce yourself, where you are, your job title, what you do, and just really an executive summary. And going to my right, Kathy, you're the first person on my screen. Why don't you go first, please?
Okay, well, my name is Kathy Good, and I direct, excuse me, I direct the Family Caregiver Center of Mercy. I was just telling Michael, we're going to celebrate our 5th anniversary in December. We support family caregivers who are caring for adults with chronic conditions, including dementia, but all other kinds of chronic conditions. Also, we support them in any number of ways. We've had contact now, I think, with about 1,200 caregivers since we have begun and opened our center. We have been impacted by the way we deliver services because of COVID. So we're doing almost everything virtually now, our support groups, our educational sessions, but we remain open, and we're happy to talk with caregivers one-on-one about their situation and help provide them emotional support and connect them with resources.
Okay, thanks, Kathy.
Does that do that enough? Or?
No, that's great. And you got in that plug in there too. That's great for the 5th anniversary.
Yeah.
Brent, please, who are you? What are you doing here?
Hey, Michael, thank you for the invitation. It's good to be back with the Iowa Ideas Conference. I'm glad you're able to do this virtually. We're facing the same thing at our association in the midst of a digital convention event. I'm the CEO of the Iowa Healthcare Association. We represent providers across the long-term care continuum. So nursing homes, assisted living communities, home health agencies, hospice agencies, medical directors that work in nursing homes, and a number of other constituency groups. We represent members in about 260 cities and towns in 99 counties in Iowa, across sort of 4 or 5 primary verticals. We do quite a bit of education and certification work for our caregivers. We provide reimbursement and public policy support to our members, and probably our benchmark program is our quality improvement program focused on improving the quality of care across the sector. So really glad to be here, and thank you for the opportunity to participate in your panel.
Thanks for being with us, sir. Brian, you come up next, at least on my screen.
Yes,
Tell us.
can you hear me?
Yes.
Fantastic. Okay, I'm Brian Kramer. I am the Director of Marketing and Sales at Cottage Grove Place here in Cedar Rapids. We are a retirement community with all levels of care, independent living, all the way through long-term care and memory. And we've been here for around 25 years. And we are, you know, dealing with what everybody else is dealing with in town with the pandemic, learning day by day. And then we had the derecho, which I guess made us learn a little bit more on how we operate. So glad to be here. Thank you.
Thank you for joining us. Okay, I'm going to start with a question that's going to be for everyone. And it has to do with, you know, we might as well just start with that, which is, you know, we have people, our parents, our relatives, in some way, our neighbors are in facilities, and we like to visit them. We want to see them. We want to advocate for them. We want to see how they're doing, and they also, of course, connect with us emotionally. And we know that the longer it goes without that contact, they tend to not do so well. And please correct me, interrupt me at any point you think I get this wrong. I'm thinking of experience with my own mother, who lives in another state. And, you know, I would try and get back there frequently, but within a very short period of time, she had absolutely no idea who I was. And I can only imagine it would have been if she hadn't seen the rest of her family. So we had a story just in the Gazette just last Friday by Michaela Ram, our healthcare reporter. And in it, she quoted, sorry, I'm working out of my basement. It's kind of dark in here. I apologize. She quoted a doctor from Unity Point Health, Dr. Cleet Younger. And he made the point his point was, if your life expectancy is 14 to 24 months, what confidence is there that COVID-19 situation will be better in your lifetime? In other words, how soon is it going to end? So my question for each of you in turn would be, and I guess, what is it you're seeing, and what is the outcome? And without making this too broad a question, what can we do? Kathy, would you want to start with that? And I know you've had your own experience.
Sure.
Where are we with this?
Sure. One of the things that occurred to me that's impactful on older adults, whether they're needing care at home, whether they're needing care in a care center, whether they're just older adults that are not necessarily needing lots of care. But I think there's an ageism issue in our society, that we have a tendency to devalue people. And I think especially because of COVID, there's some attitudes that out there that say, well, older people are going to die anyway, so if they're more isolated and they die sooner, well, you know.
Yes.
Except that some people have maybe 20 more years of good years to live. And it's interesting to me. So I guess I'm advocating for a change in our the way that we look at older people, because we certainly would not devalue the first 20 years of somebody's life the way that we devalue the last years of somebody's life. So I'm advocating for a little culture change here in how we view adults, especially because I'm an older adult and I would like to have somebody look at me with more value than just saying, well, she's going to die anyway. So that's the first thing that comes to my mind.
Brian, what are you seeing out there at Cottage Grove? I think we need to unmute Brian.
How's that?
Very good. Thank you.
So yes, you know, at Cottage Grove, I see it as everybody's living a lot longer this day and age. Our community has probably, I would say, 60% of the age of our residents are over the age of 90. So people are living longer, and with this pandemic, we're trying to find new ways for our residents, and this should be for everybody out in the public also, just finding new ways to get in touch with family members, so the people aren't being so isolated. And that's kind of one of the biggest things that we've seen, is just people being isolated, staying in their homes, and not being able to see family members, which is taking a big toll on them. So we're on a daily basis trying to figure out new ways for them to be in touch in a safe way.
Let me ask you a follow-up then. What are some of those ways? I remember we saw early on in the spring photos of young children standing outside facilities with signs with hearts on them, so their grandparents or great-grandparents could see them. There's going to be snow on the ground, and I don't know that the pandemic is going to be resolved soon. What are some of those ways? I mean, what can you do? Are you letting people in small numbers, or what? What do you do?
You know what? We're starting to get to that point now. It's kind of different per level of care. So independent living people, they are able to leave the community, visit with family members if they are in independent living. On our higher levels of care, you know, we're looking at things from doing FaceTime videos. We have a lot of that going on right now. We've also come up with a special area inside Cottage Grove, kind of like a bubble, that actual family members can come in, actually see them face to face and have a conversation. And like I said, it's on a daily basis. We're trying to think of new ways, and as every day it seems like the rules change.
Yeah.
So we're trying to, on a daily basis, just go with what the rules are, and then try to make a safe spot or a safe place for them. And they are also visiting family members outside the windows. As the weather gets a little bit cooler, that might go away a little bit more, but all those things are happening.
Michael, one of the things that I've learned about that might be possible for families to use is something called HappyGram. And so that family members, kids, grandkids can put together an email and and send it to like Cottage Grove, and they can print it out and deliver it to their resident. So that's something that people might Google, happygram.com. I don't think it's org. I think it's happygram.com. So that's something to check out. And if you're the facility, the care center that you're not connected with, the senior living community, you might talk with them about that, because it's as I understand it, it's free. So that's one way to deliver a message on some kind of a regular photo or a regular basis, photos, pictures, anything. That might just be a small thing, but small things add up.
Right. So Brent, what do you, from your perspective at Iowa Health, what do you see going on, and what are we doing? What can we do?
Well, you know, probably the most difficult decision I've ever made in my career in this space was back in March, when our National Association and State Association made the decision to advise our members to essentially lock down nursing homes 100% to visitation. That was done, ended up being about 10 days ahead of the federal government's action to require that. And I mention that because the difficulty of that decision, because even at the time, I thought I could forecast the impact that action would have on residents and families. But the reality is that it's been much more devastating. It was still the right decision. I think that the limitation on visitors for a while, the widespread restriction on visitors has saved probably thousands of lives in Iowa. What we need to do now, and what we are doing, is to pivot our process to determine how can visitation take place safely. And I'm really confident that it can. The state, the Iowa Department of Public Health, in tandem with what we call wraparound guidance with the federal government, has released standards and guidelines as to how to handle visitation in nursing homes, even as we're seeing this major spike in cases, probably a heavier spike than we've seen at all. That's because nursing homes and caregivers are better equipped with data, with information, and with equipment to help facilitate those visits. But it's absolutely critical. And I know Dr. Younger very well. He's a member of the board of our medical directors society. And when I read his comment in your piece, or in the Gazette, Speed and Michaela's piece, it hit home to me because that is a very real, very human consideration. We can't know that this situation will be markedly better in the next 12 to 14 months. I think that it will. I think the next 6 months are going to be better than the last 6 months. But the balance that we have to strike, I've found myself explaining this a lot of times, as virtually every decision that we make in long-term care right now is a decision between worse and bad and worse. Visitation is an example of that, because we know that we need to facilitate and want to facilitate visits into nursing homes. We also know that that is going to, without question, introduce more case activity into nursing homes. This is simply a math problem. The more human beings that you introduce into a nursing home or anywhere, school, hospital, what have you, house, the more likelihood you're going to have virus spread. So we are, I think, going into this with open eyes, that balancing the quality of life with the life and safety of every other resident is a decision and a choice that we don't want to have to ever have to make, but here we are. And I think that we're with our overwhelmingly our providers are doing that with a lot of thoughtful consideration and compassion. But it's a historic challenge.
Okay, don't go away. I have a follow-up question. I want to remind all of you watching, all you viewing, you can ask the panelists questions and make some comments in the chat section, and those will go through to our room host, who will forward them to me. And so please do that as we go along. You needn't wait till the end. So Brent, you mentioned staffing to some extent, and that has come up, and that is certainly part of the issue, because they aren't staying there. They go home. They go see their children. They go to the grocery store. They're out and about. Maybe not lined up at bars, but they're out and about. I want to ask you about how that works. I mean, a number of the places we're talking about in terms of long-term care centers are for-profit places. My in-laws were both in for-profit places in Louisiana. Now, I realize that's a different state. And one of the staff members came in with a very bad cold. My father-in-law got pneumonia. That didn't go well. What are there, and this is, I realize this is a dumb question. I don't mean it to be a trick question. It's a dumb question. What are the staffing requirements? What's required to get a job tending to patients, clients in long-term care facilities? Are they different place to place, or are there state regs on that?
Yes, there are state, federal regulations. The way a facility is organized from a taxable standpoint, whether it's a for-profit or a nonprofit, has absolutely no bearing on what the requirements are to work in a nursing home or assisted living program. Where the requirements differ is the job description. So, a nursing home is an example of probably is the only example I know of as robust as a labor ecosystem as you can find. That's because this is where people live. This isn't just a clinic. This isn't just an apartment. This isn't just a place to eat. This isn't just a place to entertain. This isn't just a place to convene. This is all those things. This is where people live and receive all those services. And so that's why long-term care, 80% of every dollar that's spent in long-term care is spent on labor, is spent on payroll and benefits for employees, because on average we have an employee and a half for every resident that we have in our facility. So specifically to your point, Michael, state and federal regulations at varying levels regulate what requirements are. And depending on what the job is, we have everything from custodial staff all the way up to medical directors in the facility. Obviously, a number of differences in what the requirements are to work there.
Brian, can you talk to that a bit about what staffing requirements are? What do you see when people come to work at Cottage Grove? What is their experience and their background, and how do they handle that? I mean, they do come and go, right? Of course they do.
Yep, certainly. And I and Brent can probably say this too. There is a shortage of like just nursing in, especially I think the state of Iowa, probably
Yes.
throughout the country. So we do see that there is and I always go back to the thing of, caregiving. Like if you're a caregiver at home, there's not much pay there, that type of thing. If you're, for home health agencies, coming into the home, the pay is not there. It's long hours. It can be. So I think it's just a job that some people just don't want to do. So there's a lack of it. But as far as what we see here, obviously we have everything from CNAs to nurses to LPNs, that type of thing. But I'm just going to go off of the thing that there's just a shortage of it. And that's kind of what is concerning, I think, to like just communities like ourselves, especially with how populated Cedar Rapids is now with retirement communities and that type of thing. So.
Hey, Michael, I just wanted
Yes.
to, before I don't want to jump on Kathy's time here. And Kathy, I apologize, just really quick. You asked a very specific question about staff members coming and going to the facility. That's a very important issue. How do we address that in long-term care? Primarily now, the primary strategy is twofold. It's health screening when they enter the facility, and more importantly, it's weekly or biweekly testing of staff. So we went for about 4 weeks ago, we transitioned our testing strategy in Iowa in long-term care to be in step with new federal guidelines. We went from testing about 4,000 staff members, or conducting about 4,000 tests for staff members a week, to today, we're tenfold that. We're conducting 40 to 45,000 tests a week. So what that means is we see increased case counts because we're uncovering those asymptomatic staff members and instructing them to stay home. Which is compounding the staffing crisis, but we are catching more cases now with this testing strategy. So I just wanted to touch on that.
And how confident are you, Brent, in that kind of testing that's being done? I mean, you go anywhere now, you go get a haircut and they take your temperature, and I don't know what that signifies. And they say, have you been near anyone who's been coughing lately? Well, I could lie.
Right.
No, not that I can think of.
Well, the efficacy of health screening is not great. It's a very low bar. You should do it. If you ask questions, if you've been around somebody that's been sick, have you traveled lately? Those kinds of things are obvious triggers. But what's important is actual physical diagnostic testing, and that's what we're doing in nursing homes. A combination of doing it on site through an antigen testing system, along with in most cases an outsourced. It's called a PCR test, which is like what you get through like a Test Iowa system, to get firm results to understand if that person is positive or negative. And even that is not a panacea. So a test is not a panacea. You can test negative and still have COVID in your system. We know that. So it's about stringing together a series of risk mitigation strategies to deal with the fundamental fact that we can't get around the fact that folks need to come and go from our facilities. We cannot seal them. We cannot hermetically seal them.
Okay. All right. So I'm going to pivot here a little bit. And Kathy, I'm going to come to you.
Okay.
You've spoken in more than one article in the Gazette and elsewhere about caregiving being rewarding, but it's also isolating and stressful. And you said that 5 years ago. I think 5 is the number you gave when we first started talking about elder care as a regular subject that we cover.
Right.
Could you speak about that a little bit, about how this affects the caregivers, and what can they do to help themselves and what can others do to help them?
Sure. Well, I think there are a lot of statistics that speak for themselves about what the stress does to caregivers. First of all, The average caregiver spends 24.4 hours a week in caregiving. A spousal caregiver spends 44.6 hours. I don't know how many of your viewers know that I cared for my husband, Dave. He lived 12 years, 8 at home and 4 in a senior living community. And that number was certainly true for me. And even once he went to live someplace else, I still was spending like 30 hours a week, and he was in a good place. So it wasn't like I was having to mitigate bad things. 70% of caregivers who are working when they become a caregiver, it causes them to have to change their work life due to caregiving, reduce hours, quit, take retirement. This has short and long-term consequences. There was an article in the August 25th Gazette. It talked about if a 58-year-old woman who's worked since age 25 and has contributed 10% to her 401k with a 3% match, and she stops work for 2 years, she'd lose nearly $200,000 in lost wages and retirement benefits. And if her caregiving goes on longer than 2 years, which if you have, for me, it was 12 years.
Yeah,
okay,
right.
And if she quits, this is if she quits, and she's in her mid-60s when her caregiving ends, she'll lose $765,000 in wages, plus another $120,000 in retirement and Social Security benefits, for a total of $885,000. So it has financial, short-term, long-term consequences to caregivers. 23% of caregivers who are providing more than 20 hours of their care report their health as fair or poor. These statistics they come from AARP and the Psychological Association, so I'm not just like pulling these out of thin air. 47% of working caregivers have used most or all of their savings due to caregiving expenses. 41% of dementia caregivers die from stress-related disorders before the person that they're caring for dies. 64% of dementia caregivers have a higher mortality rate than non-caregivers, and more than 60% of caregivers are at a higher risk for depression and accidents than the general population. So, I mean, there's just like, it just ripples out and it's ongoing. The longer caregiving goes on, of course, and the condition of the person that they're caring for declines, the more intense the caregiving is, the more stressful. In my case, I had health-related issues that somebody would say, well, how do you know that they were related to your caregiving? And I go like, well, if you lived in my shoes, you know that they were. Should I go on and talk about what caregivers can do to help them?
Yes, please do that. You have the floor.
Well, first of all, I think that caregivers need to realize that they're caregivers. Oftentimes people just think of themselves as wives or kids or whatever, and that's just what they do. But when you're adding a whole nother layer of work to your life and caring for somebody else, you need to recognize that you're a caregiver. And then once you recognize that you're a caregiver, you have to let go of some of the expectations that you have of how life was supposed to be, especially if you're a spousal caregiver and you never expected that as you got older, this is the role that you would be in. But the sooner that you start dealing with the reality and realize that your life is different, then the more you deal with that reality and psychologically, you get with the program. And then the next thing that we always talk about with caregivers at the Caregiver Center is to get their lives in order. Get your life in order, get powers of attorneys, wills, get the person that you're caring for, get their powers of attorney, all that sort of thing. I found that once I had my powers of attorney and all my legal things done, and I got a financial planner, an accountant, all who talk together, okay, that then if I had an issue, they could figure that out and I could focus on Dave rather than trying to wade through some of those complex issues. I realize that not everybody is my situation, but everybody should figure out what can they do to get their lives in order. And I think that contingency planning, if you're a caregiver, you need to figure out, you know, who's going to care for that person if something happens to you, because you may feel like you're going to live forever, but sometimes we don't. At the Caregiver Center, we have put together a comprehensive guide for caregivers, and we're offering sessions on taking people through that guide and thinking about contingency planning and how to get your life in order. So that's one of the sort of like the basics. Then I always think that you need to, as a caregiver, if you can, get somebody else to do the things that they can do that you don't have to do, so that you can spend time really focused on the person that you're caring for. For example, you get somebody to mow your lawn or shovel your walk or trim your bushes or that sort of thing, because somebody else can do that. If you're lucky enough to have financial means, you can hire somebody, but I'm convinced that there are people around you that would be willing to do that. And one of the things that other people can do for a caregiver is to offer that, because sometimes it's hard for caregivers to say, hey, would you mind mowing my
Sure.
grass or shoveling my walk? So, but those are the things that are kind of the basics. Then we get down to things like remembering to breathe. Okay, and that sounds so crazy when you say to a caregiver, you need to learn to breathe. But most of us, when we get anxious, breathe up here at the top of our bodies instead of down at the middle of our body. So you need to remember to stop and breathe from your diaphragm so that your belly goes out when you're taking breaths and back in. I think you need to figure out the messages that you're telling yourself, which are probably some distorted thinking about that you'll never be able to figure this out. You're not doing things well enough. So you need to talk to yourself more kindly. Like you'd never say those things to somebody else that you would say to yourself. I think it's important to write things down. I think journaling is important. Sometimes when I say journaling to caregivers, their eyes bug out and I go like, it isn't like every day, but it's just like.
Do you mean journaling, Kathy? Do you mean journaling as in, here's how I feel today, or journaling is here's what happened today, or journaling is what I need to get at the grocery store?
All of the above.
Okay.
Okay. So the more you can get things that are inside out, then you can gain a perspective or remember to do them, or all of those things. And the journal's always there. So if you want to talk about how you feel and there's nobody around to talk to, I think your journal can become your best friend. But I also think it's important to find people that get when you talk, whether that's a professional counselor, whether that's your friend or your relative or your neighbor. It doesn't matter. I think talking out our stress can be helpful. And I think recognizing your loss. I mean, caregiving involves loss, because as the chronic conditions of the person that you're caring for get worse, you know, you're losing some of the things. You're losing the person, you're losing the experiences that you had together. So Pauline Boss talks about something called ambiguous loss. And so she says that you need to mourn the losses, but at the same time, you need to remember the things that you still have, and that provides some balance. So I'll stop there because I feel like I've kind of gone on and on.
Well, before you go, you mentioned the sessions and the packets that are available, and not to give a plug to Mercy Medical, but if I know we're going to get asked, how can someone find out about where they can get those or find out about that information?
If they would simply call the Caregiver Center, 319, oh my goodness sakes, I have to think of the number here before we're over.
We can come back to that.
Yeah,
but yeah, they can find it online.
Then,
so
yeah, contact the Caregiver Center, Google us, fcgc.org is our email address. So.
Okay. Brian, I'm going to come to you next, not to put you on the spot, but I also want to remind people, if you have comments, if you have questions for our panelists or something else you think we should be talking about, do it live, do it now, and do it on your chat feature at the bottom of your screen. So Brian, let me ask you this. So Kathy was talking about what caregivers can do for themselves, how they can help themselves, and not to put Cottage Grove on the spot, but what do you see for the caregivers? I know we've talked a lot about the patients, the clients. What can a facility do to help those family members and friends who are trying to do their best? And they're not trained nurses, they're not social workers, they're not counselors, and they probably have jobs and lives. They do have lives. You know what I mean? Yeah.
Correct. Yeah. So, and I will piggyback on Kathy and just say that I think forming a plan, it's something that you don't really want to plan for, but forming a plan, have something to go off of, so you're not making decisions in a crisis situation.
Right.
I think is very much a key. That's kind of what we tell everybody that we speak with here at Cottage Grove. But as far as the caregivers themselves, we tell people, let the communities in town alleviate some of those things that you're worried about, like mowing the grass. Those communities, a lot of the communities in town like that, you don't have to worry about maintenance. They have the levels of care that are needed at the community, so they can have services come right into their home. So there's a lot of great things that come out of moving to a community like Cottage Grove. There's also respite services that you can take advantage of, where you can up to 30 days if you wanted to get away or take some time off, that you could send your loved one to a respite program.
Can you talk about that? What is that, Brian? What is that, a respite program? What is that? I know what the words mean, but what would that mean?
So basically, we have a respite, a couple of homes here designed for respite, and in our assisted living and our assisted living memory care, where let's just say somebody out in the public is a caregiver, and let's just say they wanted to go on a small trip with their family, but needed their spouse to get some, they could come live with Cottage Grove for 3 to 5 days.
Okay.
But I think it's very necessary for caregivers to give themselves that time that they need to go either play cards with their friends, or they could take advantage of something like that.
Yeah, I know my father missed his weekly poker nights, and now with the pandemic, those didn't come back, and I don't play poker.
It's a big thing, too.
I might just say too that as soon as COVID, we have some sort of end to COVID, at the Caregiver Center, we've had a volunteer companion program that's been available, so that a caregiver who needs a break, maybe just for a few hours, on some sort of a regular basis, we'll match them with a volunteer who will go into their home and spend time with the person that needs the care, so that the caregiver can go have coffee or get a haircut or go to lunch with somebody, or take a walk around the block without having to have the responsibility of care for those hours. So, and there's, as Brian, you were saying, there are also home care companies that will come in and provide that kind of companion care and provide a break for the caregivers. Caregivers need a break. And sometimes it's hard to get that to happen. It's certainly more difficult because of COVID, because our volunteer program has been suspended because of the regulations. We're a department of the hospital, and
Sure.
We just can't submit volunteers to that kind of experience. But we'll get geared back up, and then that will be an opportunity that will be available too.
So let me ask you, we've sort of talked about this, and this would be for whichever one of you wants to address this, or all of you. I read very recently, and we've reported this in the Gazette and in Iowa Ideas magazine, that something like 90% of people over 65 have one or more chronic conditions. They have diabetes and or heart disease, arthritis, depression, hypertension. And I know none of you are actually practicing physicians, but is this relatively new to have these other experiences, or is it just something we just can track this better now? And I would imagine this makes everything more complicated in helping, our older relatives.
Hey, Michael, I can start on that. the baseline statistic is not a new phenomenon. Been common for as long as we've been tracking that post 65, typically we would expect one what we would call morbid disease. What's new is, at least in the experience of long-term caregivers and the most recent data, probably in the last 10 years, is the preponderance of two things: comorbidities, so multiple comorbidities, folks that have both diabetes and a cardiac condition, for example, obesity and a lung condition, those kinds of things. That's new. That creates an enormous amount of complexity for caregivers and for long-term care. The second most recent phenomenon, which is truly heartbreaking, is the decline in age at which memory issues are beginning to emerge. So folks are developing things like Alzheimer's and dementia much earlier in life. There's not a tremendous amount of data on exactly why that is, but the data is very clear that people are developing memory issues, severe memory cognitive issues early in life, in their 40s and their 50s, which creates a lot of a new box of issues for long-term care, because in many cases you have folks who cannot care for themselves and need to receive daily care. They're going to be receiving that sort of care more than likely for several decades. And so how to handle that as a society is a real big question.
Anyone else want to add to that?
Too,
Yes, Kathy.
There are more treatments available for people. I think that then more people are screened and diagnosed. So I think that and put that together with the fact that people are living longer, and so I think that also contributes to that statistic that that you mentioned, Michael.
Okay.
I also one thing. I would say that's something that we have to, whether it's in the schools or whether it's with your kids, is to educate the younger generations on how to plan for their futures. Because when you start talking about living longer and having chronic conditions at an earlier age, you're talking financial, how do you pay for that going forward type of thing. So, it's a thing that I think it needs to be out there in the public more, in front of our kids and the younger generation, so they can start planning. I know you don't want to plan for this, but it's smart to do that.
Okay, let me shift gears a little bit, and I am, after all, also the business editor at the Gazette, so I'm going to ask you some businessy questions. And Brent, I'm going to come back to you. The Iowa Health PAC website says, and I can quote, "Never has long-term care faced such unprecedented challenges that threaten the future of our profession." And I took that meaning literally. Can you give us an executive summary of what those challenges are for profession? And if I wanted to go into this kind of work, can you tell me about the future of that? I mean, it looks like there's a lot of work, but it doesn't look like fun. And I know I'm being a bit of a wise guy on that, but.
We interchange the term. We don't use the term industry. We use the term profession when we talk about long-term care. So that particular statement references specifically the financial solvency of the long-term care sector statewide and across the country. And so at a really, really executive summary, which I can appreciate that request, we talk specifically about nursing homes. In Iowa, 52% of anybody in a nursing home is on Medicaid. So that's the social safety net system that pays for folks who cannot afford to pay for their own medical care. In Iowa, we are underfunding Medicaid by about $70 million a year. That means that on the average, a nursing home, so take half their residents, and virtually all of the revenue to a nursing home derives from daily care costs. The average cost to care for a resident in a nursing home is about $240 a day in Iowa. The state and the federal government currently is reimbursing that facility about $200 a day, creating a $40 a day delta. That means that facility is losing money on every Medicaid resident, meaning half of its income stream is upside down. That means that the sector writ large typically operates on razor thin margins. In 2017, we saw the first incidence of the sector in the aggregate dip below dip into negative operating pools, which means we were upside down. We started to see facilities close. Fortunately, the Iowa legislature in 2019 provided a shot in the arm to the sector by providing about a $25 million appropriation, which was then matched by about $75 million from the federal government. That was pre-COVID. And the last point I'll make is that we are still, and I want to make this clear, these are estimates. We don't know, these are purely estimates because we don't know the total impact. We can assess and estimate. We have some folks who are pretty good at this, have a very strong track record, that from June 30, 2020 July 1, 2020 to June 30 of 21, the sector is going to face a negative fiscal impact of about $240 million. What does that mean? That's a quarter of the income for the entire sector for the year. That has been addressed in part by about $188 million of federal stimulus dollars, but you can do the math. We're still about $60 to $70 million short in terms of the impact of COVID. That's assuming things don't get markedly worse this winter. So a number of financial challenges, a lot of solutions out there, but I want to keep this to an executive summary level, Michael.
And when you say this sector, that would encompass what?
The numbers I just mentioned were only specific to nursing homes. So there
Okay.
are other financial challenges for assisted living programs and for home health. They're just different.
Gotcha. Okay. We have a question from one of our attendees, and it is, my aunt is in a long-term care facility. She has yet to receive a haircut. It's my understanding that a federal mandate came out September 17, requiring inside visits and hair services, for example, if the county is below 10% positive. Is this accurate? Is this happening? And of course, the question is positive case numbers are going up again. And would that then go away? Is that true? Do you know anything? Can we talk about this September 17 mandate?
Yeah.
Okay.
I can clarify a little. Mostly correct, and there's a clarification in there. September 17th, the federal government released guidance as to how visitation can happen in nursing homes, which is what I referenced at the top of this panel. The guidance was not specific to what barber and beautician services. That was left to the states. So our association worked really closely with the Iowa Department of Public Health to develop guidance around barbers and beauticians. There is now what we call wraparound guidance that's available on the Iowa Department of Public Health's website that speaks to how barbers and beauticians can operate and enter nursing homes and assisted living communities in Iowa. It is targeted to the rate, and if your facility, if this particular person's loved one is in a facility in a county less than 10%, the facility has the ability to introduce barber and beautician services. They have to do it very safely. It won't happen quickly, unfortunately, because we have to limit the number of touches that these people have with our residents. But I would advise them to speak to the facility about their plans for barbers and beauticians. And again, my final point here is the really challenging piece to this is with cases increasing the way that they are in Iowa. We went from 27, what we call red counties, to 36 last week. Red County is 15% positivity or higher. And so unfortunately, positivity rates are going, and as those positivity rates increase, limitations on things like barbers and beauticians are going to be placed back onto facilities by the state and the federal government.
Brian, what are you seeing at Cottage Grove in terms of what residents kind of care that they're giving these extra? They're not really extra things, but
yeah, and people's hair, not mine, but people's hair is pretty important to them. So it's we've been actually, going on a case-by-case scenario where it's an appointment. We can't have multiple people actually getting their haircut at the same time. But we have been able to, like I said earlier too, it's a day-by-day, hour-by-hour thing that we go by a lot of what the rules are, but we also we're taking a little bit more safety precautions than I guess you'd say normal. So it can change on a day-by-day. Day by day, we're looking at it, making sure that it's safe for everybody. but we are doing some of those things for our residents as far as getting their haircuts and stuff like that. So.
Okay. You know, and as happens when we do this live, the questions come in toward the end. So we are getting questions now. And I do want to tell everybody we've got about 8 minutes left in this panel. So if you have any questions, now's the time. So here it is. This one asks, what can be done to address the socialization needs of healthy persons aging in place in their homes? And Kathy, maybe this goes to you. The person mentions that Iowa City has a great community center, but not every place does. Again and again, healthcare articles say loneliness is a major health issue for elderly. You know, doing Zoom meetings help? And you mentioned the Google Grams, but that obviously depends on the person at home being able to operate a computer and having an internet device, as they call them.
And I think one of the things that I would really encourage every older person to do is to become more tech savvy. And I know that that's just scary, and people fear that they won't be able to do it, but anybody that can find a smartphone or an iPad, I think it's the wave of the future. And I think that older people need to kind of like expand their horizons and find a younger person, a member of their family, their neighborhood teenager, somebody that can help them learn that. And I realize that this is COVID and we have to be safe, but I think it's really important. I think my own, I mean, I started out, I didn't know about Zoom when we were here at the center going like, okay, well, we've got to get a Zoom account. So we are capable as older adults to learn, and I think that's one of the ways to become less isolated. I started doing happy hours with my friends in Michigan, things that wouldn't have really even have been possible before I got, you know, more tech savvy. So I think that's one of the really things that is important for older people to do, is to open themselves to that possibility, because, you know, I've played games with friends. We play Yahtzee. We have a game night. So I think that that's part of the way to reduce the isolation. Plus then you can zoom into things like that are all kinds of availability with groups and organizations that are, it's the wave of the future. Plus, I think we're going to be doing our banking and all of the things that we used to do in person. I think we're going to do them virtually. And so I think it's just really important. And any caregivers or any family members, I think, can encourage older adults to become more savvy. So that's one of the things. And I know it's not for everybody, but the more people that do it, the more that it reduces some sense of isolation. Not that it's not nice to see people in person, but this is a pretty good substitute.
And we've been asked again, Kathy, if you could repeat some of that information about those packets.
Yes. So, and I have now the phone number and our correct email address. I just don't know why that didn't happen before. Anyway, so you can contact us at the Family Caregiver Center of Mercy, and the phone number is 319-221-8866. And our email address is fcgc@mercycare.org. And we will be happy to tell you when our next round of planning sessions will be held. And during those sessions, then you would receive one of our comprehensive planning guides that will guide you through the process of kind of what I call getting your ducks in a row.
Okay, thank you. I just got our 5-minute warning. So if you have any questions, comments out there, now is absolutely the time. So let's do a round robin. And as we close out here, and there are many, many, many other panels still going on today, and I have another one right after this that I need to go to. But let me ask each of you in turn, What do you see going forward? What are some things we can do? Do we just keep on keeping on with how we're helping our elderly? I mean, there are a lot of issues we didn't talk about. We didn't talk about phone scams, to which the answer is don't give out your credit card, just hang up. But you have to know, I guess, that it is a scam. You know, elder abuse, there are a lot of things we still haven't talked about. But what are some other things we could be looking for? How can we help our elderly? What should we be thinking of? What do we need to be aware of? And I know that's a pretty open-ended question.
Well, I think since there's going to be a lot more older adults that are living and living longer, we need to focus on the strengths that they bring to our society. And, you know, we've talked a lot about, you know, the downside and the chronic conditions and the caregiving hassles and the stress of all of that. But there's so many strengths that older adults bring to our society that I would really encourage all of us to think about and focus on those strengths, not just on the issues that exist.
Ryan, what say you? Final thoughts?
Yeah, I think that you know, in the near future, obviously we have the holidays coming up, and during this obviously this pandemic and getting through this storm, and just making sure that we're keeping an eye on our seniors, our friends, making sure they're doing okay, because a lot of times the holidays is the only time that they do see family or talk to family. So if we can help out in any way of getting them in front of them or talking to them, that's kind of what I would throw out there, just looking at in the next few months. So.
Okay, good thought. Brent, what's going on? What can we do? What do you see coming up? How can things get better?
Well, you know, and with respect to COVID, every viral epidemic in recorded history has had a beginning and an end. This will also have one of those. When we look further out, Kathy touched on it. The age of the population in the United States is growing older. It will grow much older over the next 25 years. And the costs associated with, I hate to make a dry fiscal assessment, but it's incredibly important. The costs associated with caring for those people are incredibly high. And yesterday, Seema Verma, who's the head of the Center for Medicare and Medicaid Services in the federal government, made an announcement in a press release saying that she was shocked that all of their efforts to draw down the cost curve with respect to something called value-based purchasing for Medicare, which has been a major priority for them, haven't worked. And you know, I chuckled when I read that, because we know that's the case. It simply costs a lot of money to care for people who are older because they have very complex medical conditions. And so we need as a society to accept that, understand that, and find ways to fund their care. If we don't do that, we're going to face an incredible level of social unrest, in my opinion, in the next 10 years, because we're going to run out of money to care for people in their 60s, 70s, and 80s, as 60 and 70% of them enter Medicaid period of time. So big cliff issues ahead of us fiscally as a society. And so I think that's what we're thinking long range when we get out of the other side of this pandemic.
All right. I just got our 30-second warning. I want to remind everybody there are lots more panels to come. I want to thank our panelists, Brent, Kathy, Brian. Thank you for taking the time. Thank you for doing this. Thank you for the good, informative thoughts. I'm going to turn this back over. Michael, do you want to take us out?
Yeah, most certainly. Again, thank you everyone for you know, participating in this. To the panelists, to Michael, you know, thank you very much. We understand this is kind of a unique situation and never had an Iowa Ideas Conference like this before. So we do appreciate everyone working with us, and we hope to see you guys in the next session and later on today for the social. So have a great day, guys, and we appreciate it.
Bye. Thank you.